back to our channel. Now we are going to start motor system complete revision physiology. So first we are going to start with descending motor pathways. So the main motor areas are, they are mainly efferent pathways output, and they're also called as descending pathways. So their efferent pathways means they are carrying the information from the brain and now towards the spinal cord. So they're moving like from the cortex to the spinal cord. Hence these pathways are also called as corticospinal pathways, and they're mainly coming from the motor areas which are present in our cortex. And these are also called as descending pathways because they are coming now from upward to downward. Before we are seeing the sensory pathways which are going from the spinal cord to the brain. So those are ascending pathways and these are the descending pathways. And now let us see the motor areas. They are mainly present in our motor cortex and they are called motor cortex areas, which are mainly corresponding to Brodmann areas 4 and 6. So actually Brodmann is the scientist who has numbered the cortex areas. In somatic cortex we have seen the 2, 3, 1 areas, Brodmann cortex, right? So here there are 4 and 6 according to the motor cortex. So there are 3 cortex areas which are present in the frontal area, precentral area. So for example, what is this precentral area? We already discussed in somatic physiology already. For example, this is a central sulcus, and in front there is a precentral area which is a frontal area, especially motor cortex. And behind this central sulcus we have a postcentral area which is mainly a posterior cortex, which is sensory cortex, where we have the somatosensory area 1. So here you can see there are the 3 cortex area especially present in the frontal area, precentral. There are mainly 3 motor cortex. So first one is primary motor cortex, next one is premotor cortex, means primary motor to the primary motor cortex, they are pre, means in front of primary motor cortex we have premotor cortex, and we also have some supplementary motor cortex. So these are the main 3 cortex areas. The primary motor cortex mainly corresponds to Brodmann area 4, and its main function is to execute the final motor movements. That is nothing but our motor, why our motor fiber is coming to form the movements in the muscles. So the main function of this primary motor cortex is to execute the final motor movements. But before that, it also needs some cortical association area, which is useful for mainly generation and initiation of the idea. So first, if we have some idea to do some kind of work, then only we will start that work. If at the beginning if we don't have any idea or any initiation, then we can't do it, right? This is also same for our brain. So especially to the primary motor cortex, it has a cortical association area which is mainly leading to generation and initiation of idea, and that idea is executed by the primary motor cortex as doing the final motor movements. Next, let us move on to the premotor cortex. So premotor cortex mainly corresponds to Brodmann area 6. So 4 is for primary cortex, premotor cortex, Brodmann area 6. The main function is setting of posture. For example, now I am saying this video, so I should change my posture if I want to suddenly get up from this. So it's like changing the posture. So how you are changing the posture, that is mainly based on your premotor cortex. And next, coming to supplementary motor cortex. So it's a mainly corresponding to the Brodmann area 6. So premotor cortex, supplementary motor cortex, both are corresponding to Brodmann area 6. Only the primary motor cortex is corresponding to Brodmann area 4. And the main function of this supplementary motor cortex is it's responsible for bimanual coordination. Bimanual coordination means 2 sides. For example, now my hand is here catching a pen, and on one hand, on other side it's catching the mobile phone. So you can see here bimanual coordination is required now even to say this lesson now. So that is what bimanual coordination, and it is done by supplementary motor cortex. So if you take examples and if you learn, it will be very fast and easy to understand. And next, let us move on to corticospinal tract. So this is the main one. Corticospinal means from the brain cortex, it will start at the brain cortex and it will end here in a spinal cord. So the tracts which are descending from the cortex to the spinal cord, those are the corticospinal tracts. These are also called as pyramidal tracts because they are like passing through that kind of cell. So hence they are called as pyramidal tracts. And the fibers which descend from cortex to spinal cord, and they descend through the lateral column, so called lateral motor pathway. So actually if they are moving from lateral side, then lateral motor pathway, and if they are moving from ventral side, ventral motor pathway. So like that, as most of these are moving from lateral side, we are calling them as even lateral motor pathway. And next, the origin is mainly layer 5 of cortex, that is bed cells. So remember, actually in our cortex, especially in the layer 5, we have bed cells, which are the main, it's giving the main origin for our corticospinal tract. Now let us see the contribution for this formation of corticospinal tract. Mainly we have 30% contribution from primary motor cortex, and 30% is from premotor and supplementary motor, and 40% is from sensory cortex. So you can see here, even though this is a motor pathway, now we are talking about a motor pathway, right? But you can see the sensory cortex is playing the major role, 40% among all this, because you can understand that by efferent the information will be coming to the sensory cortex. From there only the efferent will come, that is the motor. So mainly the sensory cortex is playing a major role, from which the efferents are coming, and even 30% is from primary motor, 30% from premotor, and also supplementary motor. These are the percentage we need to remember. And 80% of the corticospinal tract is crossed to the opposite side, and that is especially towards the lateral side, so it's a lateral corticospinal tract. And the 20% of the corticospinal tract is uncrossed, means it's on the same side, ipsilateral side, so it's called as ventral corticospinal tract. So mainly we have two types of tracts, ventral corticospinal tract and lateral corticospinal tract. The ventral one is like it is traveling in the same direction, ipsilateral, with the opposite one which is crossing, it's a lateral corticospinal tract. So mainly we say the corticospinal tract is lateral. Let us see the brainstem motor pathways. So there are mainly 4 motor areas, 4 pathways for it, and these are all the extrapyramidal tracts. So only the corticospinal tract is a pyramidal tract, but this 4 other pathways are extrapyramidal, like we have reticulospinal tract, vestibulospinal tract, tectospinal tract, and from our red nucleus we have rubrospinal tract. So you can see these 4 other different tracts are mainly coming from other, means rather than pyramidal cells, so we are calling them as extrapyramidal tracts. So let us see what these tracts, what they are going to do. So mainly the reticulospinal tract, vestibulospinal tract, tectospinal tract, these 3 are going to descend medially, and they will finally as they are descending medially, we will also call them as medial motor pathways. So see, these are descending medially and we call medial motor pathways. And next we have our rubrospinal tract, which is coming from red nucleus. It is descending laterally, so it's called lateral motor pathway. So in this extrapyramidal tracts also, again we have the medial motor pathways and lateral motor pathways. So in lateral motor pathways we have exclusively rubrospinal tract. Now you can see here the reticulospinal tract also have other 2 components, that is a pontine reticular tract and medullary reticular tract. The pontine reticular tract is mainly excitatory, whereas the medullary reticular tract is inhibitory. Both this act upon the limb extensors especially. So reticulospinal tract has some importance of 2 components, which is one of it is excitatory and one of it is inhibitory, especially on limb extensors. Next let us see the rubrospinal tract. It mainly controls the upper limb flexors. So upper limb flexors by rubrospinal tract, which is a lateral motor pathway. Now let us see once again, let us conclude, summarize all these pathways, what they are doing, what are the functions, evolutions. So first let us start with our corticospinal and rubrospinal. You can see they are mainly lateral motor pathways, right? Both the corticospinal, rubrospinal are lateral motor pathways, and the medial motor pathways are all the remaining reticulospinal, vestibulospinal, and also tectospinal tract. Next, coming to the functions, the main functions of this lateral motor pathway like corticospinal and rubrospinal is helpful in writing. Now as we can write only because of this pathways which lead to contraction of distal muscles. Distal muscles are nothing but our finger muscles, our hand muscles. These are all the distal muscles, and that too they are providing the voluntary movement, and that is a fine motor movement which are used for skills, different skills. So it's a fine motor movement mainly by lateral motor pathways, whereas the medial motor pathways are mainly useful for posture maintenance, especially by contraction of proximal muscles. So for example, this is a hand and this is the distal one, and this is the proximal one. The proximal one is mainly useful for posterior maintenance and also control the paraspinal muscles and also anti-gravity muscles. So these all are useful for the posture maintenance. And you can see evolution. The evolution of lateral motor pathways is recent. It's a very new evolution, whereas the medial motor pathways are already the oldest evolution. So these are all some of the important points about descending motor pathways. Next, let us see other part. So now we are going to see about motor neurons. So motor neurons mainly arise from the cortex and also from the brainstem. So either if they arise from the cortex or brainstem, we have the same name, that is the upper motor neurons. So upper motor neurons are the one which are present either in the cortex or in the brainstem, and later they descend up to the spinal cord. After they descend into the spinal cord, in the spinal cord they are called as lower motor neurons, and the lower motor neurons are the one which only going to innervate the skeletal muscle. So the skeletal muscle is mainly innervated by the lower motor neurons, but the upper motor neurons also have a control on this lower motor neurons. The main control of this upper motor neurons is, upper motor neurons whenever it is present, it always tries to inhibit the lower motor neurons, so that there would be not more excitation or more contraction of muscles. So this upper motor neuron is always like keeping the lower motor neuron in check. Like only whenever the contraction is required, it will stop this inhibition function, and it will lead to contraction of this muscles by means of lower motor neuron innervation. So it mainly innervates the skeletal muscles, and here you can see we mainly have the two types of skeletal muscles, the alpha motor neuron and the gamma motor neuron. So you can see the lower motor neuron activates the skeletal muscle, especially those are divided into alpha motor neuron and gamma motor neuron. The alpha motor neuron mainly innervates the extrafusal fibers, and the gamma motor neuron mainly innervates the intrafusal neurons. So what are these neurons of extrafusal fibers, intrafusal fibers? Let us check out. So you can see, for example, this is a skeletal muscle. Inside we have the intrafusal fibers, and outside we have the extrafusal fibers. The extrafusal fibers are mainly, you can see here, AM. This A is an actin and M is a myosin. These are the extrafusal fibers, and this inside which are present inside fibers, those are called as intrafusal fibers. So intrafusal fibers are mainly activated by gamma motor neuron, and it regulates the muscle tone, and you can see here the skeletal muscle. And next, the alpha motor neuron mainly innervates the extrafusal fibers, and it's useful for mainly muscle contraction. So alpha motor neuron for muscle contraction, gamma motor neuron for the muscle tone regulation. So these are both are in the control of lower motor neuron, which is present in the spinal cord, and this lower motor neurons are in turn in the control of upper motor neurons, which are present in the cortex and brainstem. So this is how the descending pathway act, and they control all this muscle contractions and maintenance of muscle tone. Remember, the upper motor neuron is always inhibiting the lower motor neuron. Whenever only it is necessary for contraction, then only it will inhibit, it will stop this inhibition, and it will lead to allowing the contraction of muscle. Now let us see the decerebrate posture and decerebellate rigidity. So what is this decerebrate posture? So the complete transaction at the brainstem level between the superior colliculus and inferior colliculus. So for example, if we cut our brainstem between the superior colliculus and inferior colliculus, let us see what happens to our muscles. So mainly this corticospinal and rubrospinal tract function are lost. So actually this corticospinal and rubrospinal both are the lateral pathways. So if both these lateral pathways are lost, what happens? And the brainstem pathways like reticulospinal tract become overactive. So why reticulospinal tract become overactive? As I said, this upper motor neurons always inhibit this lower motor neurons. So now as we cut this brainstem, the upper motor neurons can no more inhibit them. So the reticulospinal tract will become overactive as this upper motor neuron is not inhibiting them. So because of this overactiveness of upper reticulospinal tract, it will lead to extensor rigidity or gamma rigidity. So extensor rigidity means the extensor muscles will become more rigid, that they can't move because of the overexcitation of reticulospinal tract. And the extensor muscles and gamma motor neurons, forearm will undergo pronation. The position the person looks is, his forearm will be pronated, and the extensor muscles and the gamma motor neurons, they'll become rigid. This is that is how the person looks in the decerebrate posture. And next, let us see decerebellate rigidity. So you can see here the cerebellate word. cerebellum. This is about cerebellum. That is about cerebrate means cerebrum. So here now we want to talk about decerebellar rigidity. So it's mainly removing the anterior surface of cerebellum. So in this person only, in this decerebrate posture person only, now if we're doing experiment by removing we are removing the anterior surface of cerebellum, then this extension rigidity is exaggerated, means it is increased. So even if the cerebellum is also, if you are cutting down, then this situation is getting more exaggerated, and the alpha motor neuron is also now undergoing overactivity, so it will also in turn lead to alpha rigidity. So this is what we need to understand about this decerebrate posture and decerebellar rigidity. Now let us see decorticate posture. So decorticate posture is, if you remove the cerebral cortex, only corticospinal tract is lost. So only if you remove the cortex, then only corticospinal tract is lost, and the rubrospinal tract is still intact. So rubrospinal tract now will become overactive. It will lead to extension of mainly lower limb, and if reticulospinal tract is overactive, it will lead to extension of lower limb, and rubrospinal tract overactive, it will lead to flexion of upper limb. Flexion means like this, the upper limb will become nearer like this, flexion. And clinically this is a decerebrate posture, and it is mainly seen in ankle herniation. So clinically, if we want to see the person who is in decerebrate posture, we can see the person who is having ankle herniation. And decorticate posture is also seen in a thrombosis of internal capsule. So internal capsule is also one of the structure by which the motor pathways pass through. Especially the motor pathways pierce the posterior part of the internal capsule. So if there is any thrombosis of internal capsule in that person also, we can see the decorticate posture. Now let us see the lesions of upper motor neuron and lower motor neuron, and also what is Babinski sign. So let us check out. First we will see upper motor neuron. So muscle atrophy. Muscle atrophy is not seen in upper motor neuron, because upper motor neuron is usually inhibitory, right? So now it is, if it is lost, if there is lesion, means of course it will not undergo any inhibition, so no atrophy. But in the lower motor neuron lesion, you will see the muscle atrophy, because it's normally excitated type of neuron. And next coming to muscle fasciculation. Muscle fasciculations are nothing but sometimes inside your muscle you can see some movements are going on, like continuous movements for some time, and again they'll go. Those are called as muscle fasciculations. These are not seen in upper motor neuron lesion, because it's usually inhibitory. But in the case of lower motor neuron lesion, you can easily see this. And next coming to muscle reflexes. Muscle reflexes are exaggerated in the upper motor neuron lesion, because it's usually keeping them inhibited. Now this has gone, so there is a lesion there, so now the muscle reflexes will be more. Whereas in the lower motor neuron, there will be no muscle lesions or no muscle reflexes. And muscle tone is spastic in the case of upper motor neuron lesion, because now as this impulse is only not coming, so the muscle will get thick and rigid in the case of upper motor neuron lesion. Whereas in the lower motor neuron lesion, the muscle tone will become flaccid or hypotonic. Flaccid means it will become loose, because lower motor neuron is no more to excite it, so the muscle will become so loose and like so rubbery like structure, and also it will become hypotonic. Now let us see what is Babinski sign. So Babinski sign is nothing but on striking the lateral surface of foot. So for example, we'll draw a foot here. So for example, this is a foot, and if we try to pull on the lateral side of the foot like this towards fingers like this, if we'll draw like this with the help of some metal structure, if we try to do this on the plantar flexure, that is on the back side of your leg, that is on the sole of your leg, then the normal is the plantar flexion of all toes. This is called negative Babinski sign. Like when you do this, your flexion, there will be plantar flexion, and also your great toe will be and all your fingers will be moving inward. Means for example, these are your toes. Think my hand as toes. So when you do this plantar Babinski sign, all your fingers will move like this. But in the upper motor neuron lesion, what happens is only the great toe will be moving like this, and all these fingers will fang out like this. So that says it's a positive Babinski sign. So you can see here, in a normal person, the plantar flexion of all toes is negative, that is negative Babinski sign. Whereas in upper motor neuron lesion, the dorsiflexion of great toe and other toes fans out, that is a positive Babinski sign. So this is all about our descending motor pathways quick revision. Next let us move on to the spinal reflexes. Let us continue our revision series on our motor physiology. So now we are at spinal reflexes. So mainly what are the components of the spinal reflex? Let us check out. Mainly it has 5 components. So for any reflex arc, this spinal reflex is also known as reflex arc. So for any reflex arc, first we need the 5 components. The main first one is a receptor, which is a sensor. So for everything, of course, there should be receptor which should be sensing what is going on, right? And later from the sensor it will give the information to the brain by means of an efferent. So an efferent is a sensory input which will take the information from the sensor or receptor. So we will take it in an example so you can easily understand. For example, now a pinprick. So now as pinprick has come from a leg, so the receptor sensor is in the leg, and from there the sensory efferent will be going to now the center, that is the spinal cord, and in the spinal cord there will be some processing, and in turn it will give the information to the motor efferent, which is an output. So because of this output we'll get the desired response. So this is a 5-step process which is also called as reflex arc. So it's the most common one, everyone knows this. But again, let us revise in this topic, spinal reflexes. And next, let us see what is stretch reflex. So this is very simple. This is the simplest reflex, just a passive stretch of a skeletal muscle. Just a passive, means a slow and passive stretch of a skeletal muscle. It induces a muscle contraction. So just if you stretch the muscle, it will lead to contraction. That is a stretch reflex. So for example, we'll see with an example and you can understand. So first let us see the main important, of course most common one is a knee jerk reflex. So for example, the quadriceps muscle is stretched mainly using a knee hammer. So with the hammer we will beat at the quadriceps muscle and it undergoes contraction. It's a passive stretch, and the examiner stretches the muscle and not the patient. So actually the patient himself will not stretch his own muscle, right? Here the examiner, otherwise a doctor will be there who is using this knee hammer and beating at the quadriceps muscle so that it will undergo contraction. So it's a passive stretch process, and the sensor receptor of the stretch receptor here is called as muscle spindle. So very important, the receptor here is muscle spindle. So from this muscle spindle now the information goes to efferent, and from the efferent by motor efferent the response comes, that is nothing but contraction of this muscle. So this is nothing but stretch reflex, especially called as passive stretch reflex of the skeletal muscle. Next, mainly we have extrafusal and intrafusal fibers which are placed parallel to each other. So in a muscle spindle actually you have a for example, you can see here, this is a muscle spindle. You have this AM, this are actin, myosin, these are the extrafusal fibers, and inside you will have the intrafusal fibers, and they both are arranged in a parallel fashion. And each muscle spindle can contain about 3 to 12 intrafusal fibers. Very important. Each muscle spindle has 3 to 12. So this muscle spindle is nothing but what? A stretch receptor. So now we are talking mainly in a detail of stretch receptor. So stretch receptor have both muscle spindle both the 2 fibers, extrafusal fibers and also intrafusal fibers, and the intrafusal fibers are mainly 3 to 12 fibers. So this is important about muscle spindle. Next, let us see the details of extrafusal fibers. So in extrafusal fibers mainly you can see here AM, these are the actin and myosin, they are arranged like this alternatively, and the muscle spindle innervations are mainly spindle sensory efferent. So what is a spindle sensory efferent? Let us understand the muscle spindle innervation. So muscle spindle innervation is divided into sensory efferent and motor efferent. So once let us see the sensory efferent. Sensory efferent is nothing but the spindle sensory efferent. It's also called as primary efferent, or also called as annulospiral endings, or also called as group 1A efferents. So see, sensory efferent have many names to remember: spindle sensory efferent, primary efferent, annulospiral endings, group 1A efferents. So if we understand this pathway, everything will be covered here. First we'll see what they are called. So the motor efferents, these are E. Motor efferents are called secondary efferent. They're called as flower spray endings and also called group 2 fibers, just opposite to them. Here they are called group 1A and here they are called group 2 fibers. And they have their annulospiral endings. Here they have flower spray endings. And there are secondary efferent and they are primary efferent. So here you can see the spindle sensory. Yeah. So see a spindle sensory efferent is of sensory efferent. So once let us see what is going on here. So for example, you can see here especially the impulse from the spinal cord is coming. So this is a primary efferent here. I didn't mention in this diagram, this is the primary efferent and this is the secondary efferent. So you can see here the primary efferent is also called as annulospiral endings, and they are mainly group 1A efferents, and especially they go to the nuclear back fibers to both static and dynamic. You can see this is a primary efferent. You can see it is going to both static and dynamic, which is nuclear back fibers. And next it also goes to the NCF. NCF is a nuclear chain fibers, right? So this is the primary efferent. You can see it is going to both static and dynamic of nuclear back fibers, and also you can see it is going to the nuclear chain fibers. Done. Now let us see what is secondary efferent, where it is going. Secondary efferent is also called as flower spray endings, and these are the group 2 fibers. They mainly go to nuclear back fibers, only static. This is very important, it's an exception. The secondary efferent goes only to the static. You can see the group 2 fibers going only to the static but not to the dynamic, but group 1, that is primary efferent, goes to both static and dynamic of nuclear back fibers, and of course this also will go into the nuclear chain fibers. So very important topic. The primary efferent goes to both static and dynamic of nuclear back fibers and also goes to the nuclear chain fibers, but the secondary one goes to the nuclear chain fibers also, but in the nuclear back fibers it only goes to the static one. And next let us see the muscle spindle innervation. It is also called as motor innervation. So motor innervation is mainly done by gamma motor neurons and the motor supply of the muscle spindle. This gamma motor neuron mainly supply the give the motor supply to the muscle spindles. So it is divided into dynamic gamma efferent and static gamma efferent. Dynamic gamma efferent goes to dynamic nuclear back fibers, and it is also called as plate endings in muscle spindle. So very important, dynamic gamma efferent goes to dynamic nuclear back fibers. You know already nuclear back fibers, in that the dynamic one will be getting a dynamic gamma efferent, and this is also called as plate endings in muscle spindle. Very important word. And next, static gamma efferent is going to the static. So remember here one thing, before we are talking about efferent, now we are talking about efferent. So the static gamma efferent goes to the static nuclear back fibers and also to the nuclear chain fibers, and it is also called as trail endings in muscle spinning. Very important. You can see dynamic one is only going to the nuclear back fibers, dynamic only. It is not going to the nuclear chain fibers, but the static gamma efferent is going both to the static nuclear back fibers and also it is going to the nuclear chain fibers, and this is also called as trail endings. That one is called as plate endings. And next you can see here actually this is a muscle spindle receptor in the middle, especially which is seen in the intrafusal fibers, and two sides we have the periphery which is supplied by the gamma motor neuron. So when the gamma motor neuron is stimulating them from the two sides, it gets stretched. Because of the stretch only there is a reflex going on. Now let us check out the components of stress receptor pathway. So it has a receptor muscle spindle input or efferent, which is a spindle efferent, and it also has a center spinal cord. We already discussed all this. So the spindle efferents are mainly monosynaptic reflect and they activate the alpha motor neuron. Very important, spindle efferents activate the monosynaptic reflex by activating alpha motor neuron, and the output are the efferents are especially the alpha motor neuron is activated. So output efferent alpha motor neuron is activated mainly by means of a monosynaptic reflex, and the response is muscle contraction. So whatever we are talking, the components of stress receptor pathway. Stretch receptor pathway means whenever there is a stretch in a skeletal muscle, how there is a muscle contraction. First there is a receptor which is a muscle spindle, right, and there we have an input or efferent which is a spindle efferents, right. That spindle efferents only will undergo the monosynaptic pathway and they will give the information to the alpha motor neuron which is a efferent. So that alpha motor neuron will be activated and finally the response is coming, that is a muscle contraction. So next let us see the direct and indirect muscle contraction. So muscle contraction occurs mainly in two ways, either directly or indirectly. So the direct contraction is where the alpha motor neuron activation mainly activates the extrafusal fibers, the actin and myosin, and causing the muscle contraction. So very easy process. Directly the alpha motor neuron will activate the extrafusal fibers, that is actin and myosin, leading to contraction. Whereas the indirect muscle contraction is where the stretch reflex is induced here. How it is induced? First it activates the gamma motor neuron activation in the periphery, and this gamma motor neuron stretches the central receptor and induces a stretch reflex, and this activates the alpha motor neuron causing the muscle contraction. So you can see in the direct pathway, directly the alpha motor neuron is activating the extrafusal muscle and causing contraction. But here it's indirect pathway. First the gamma motor neuron is activated. In the before diagram, if you remember, in the before diagram you have seen in the both periphery ends we have the gamma motor neuron. So because of its activation, it will stretch the receptor. Because of this stretching of the receptor, it will induce the activation of alpha motor neuron and in turn leading to the muscle contraction. So it's an indirect pathway. And the alpha gamma co-activation. So what is this? At the same time, both alpha and gamma can be co-activated to achieve a purposeful muscle contraction. Both the alpha and gamma motor neurons are activated together at the same time. So sometimes this may also takes place like alpha and gamma both together. So till now we have seen direct pathway, there alpha is directly activated. In the indirect pathway, the gamma is activated, and also we have another pathway where alpha and gamma both are activated together, that is called as co-activation. This is mainly to achieve the purposeful muscle contraction at the same time. And now let us see the inverse stretch reflex. So what is this inverse stretch reflex? It is a preventive stretch reflex which prevents the muscle injury by overstretch. So before all, till now we have seen how because of stretch there is contraction, but now we are going to see inverse stretch reflex. Here there is a preventive stretch reflex which prevents the muscle injury. So overstretched muscle will undergo the relaxation process. So how the relaxation is taking place by overstretch, let us see. The inverse stretch reflex follows the opposite sequence of normal stretch reflex. It is also called as lengthening reaction, because whenever the muscle has undergone the stretch or overstretch, then only it will starting relaxation of the muscle. So it is called as lengthening reaction. And the components of inverse stretch reflex, of course, they also have a receptor. The main receptor here is Golgi tendon organ. So remember, the muscle spindle is a receptor for the contraction, and the Golgi tendon organ is a receptor for the inhibition or relaxation of a muscle contraction. So every Golgi tendon organ encloses around the 3 to 20 muscle fibers and stimulates the overstretch. So whenever there is overstretch, you can see the Golgi tendon organ is around the muscle, so that it can sense whenever there is overstretch, it will sense the overstretch and gives the input efferent by means of group 1B efferents, and these group 1B efferents go to the center spinal cord, and by means of input it will it is nothing but input is here overstretched to the spinal cord, right? So it will send the efferents. The efferents are mainly 1B efferents overstretched to the inhibition neurons, that is Renshaw cells. We know that Renshaw cells are the inhibitory neurons because of having a neurotransmitter as glycine is a main neurotransmitter. Also it will have the GABA. So because of this, it will lead to inhibition of alpha motor neurons, causing a muscle relaxation. So of course, before we are seeing if the alpha motor neuron is activated, then muscle contraction. So here the alpha motor neuron is inhibited, means muscle is relaxing. So the main neurotransmitter is glycine. Of course, GABA is also used, but the main one is glycine. And this is a disynaptic reflex. So remember, for the contraction of muscle, for the activation of alpha motor neuron, we need a monosynaptic reflex. But for the relaxation of muscles, skeletal muscle, we need a disynaptic reflex. Why disynaptic reflex? Because you can see in between we also have one more inhibitory neuron. Renshaw cell is activated, and next inhibits the alpha motor neuron. There you can see directly the spindle efferent is acting on the alpha motor neuron, but here we have an intermediate Renshaw cell, so it's a disynaptic reflex. Next, let us see the output or efferent is again a alpha motor neuron is inhibited finally, and the response is muscle relaxation. So remember, Golgi tendon organ leads to muscle relaxation because it is around some 3 to 20 muscle fibers, so that it can sense whenever there is a overstretch, and this is also called as lengthening reaction. Now finally we have come to a table to summarize all this contents here today which we have discussed. So let us check out again them. The stretch reflex and inverse stretch reflex, or the lengthening reaction. So the receptor for the stretch reflex is of course stretch, for the inverse overstretch, and the input or efferent is of course muscle spindle, and here is of course Golgi tendon organs, and here the input or efferent sensory are group 1A, group 2. Here the group 1B is efferent, and the center is both spinal cord, and the output or efferent is the alpha motor neuron activation, and here of course alpha motor neuron inhibition, and the response is here contraction, the response is here relaxation. The synapses are monosynaptic, and here the disynaptic 2 synapses. So I think by revising just this box we can again remember everything, recollect everything. This is the main box for in today's discussion, and we will have some last part, and we will continue next with the cerebellum and the basal ganglia, the last part of the motor physiology. So now we are at muzzle receptors. So muzzle receptors are mainly having a muzzle, spindle, and also Golgi tendons. Of course, muzzle spindle is for contraction of the muzzle, and Golgi tendons is for inhibition of contraction. So this is also called as length sensors. These are also called as tension sensors, of course, because when a contraction, the length increases, and whenever there is higher overstretch, of course, tension in the muzzle will increase. Next, let us see the polysynaptic reflex. So it is also called as withdrawal reflex. So this is especially the main example is pinprick on a right foot. So if you are running in a thorny area or some pin is pricked to a leg, what happens, let us see, especially to the right foot. Here we took as an example. So in the right lower limb there will be flexion. Flexion means the leg is coming near to your body. Why? Because you are touching a pin, so you should immediately do the flexion. So all flexors are of course activated, but the extensors are inhibited here, because now you need to not extend. If you extend more, then again there will be again pin prick. So to prevent that, here the flexion will be there in the right lower limb, whereas in the left lower limb you will see extension. Why? Because you need to support now on the only left leg to hold your body there, so to maintain the support. So here the all extensors are activated, but the flexor is inhibited. Means all extensors are activated on the left leg, means now the left leg will hold the ground very tightly with extension, whereas on the right side you will see the flexion. So very simple concept to understand. Now let us see the positive supporting reflex and mass reflex. So what is this? Let us see. Positive supporting reflex is also called as magnet reaction. It mainly helps to maintain the balance, pressure on the footpad of animal, extension of the same limb. So actually this is a positive supporting reflex, means it is a magnet reaction, help maintain the balance, pressure on footpad of the animal. On which side now we want to send, that side the extension of the muzzle will take place, and it will help to further balance and extension on the same side of the limb, so that you can maintain the balance. And the mass reflex. Mass reflex is an integrating center. For the mass reflex we have integrating center of the spinal cord, and classically seen in paraplegia. Paraplegia disease people. Mild painful stimulus causes profuse sweating, and systolic blood pressure rises greater than 200 millimeters. So just for mild painful stimulus only, they'll have more sweating, and also they'll have higher blood pressures and evacuation of bowel and bladder. So the purpose why we do this mass reflex is we want to evacuate the bowel, and also we want to evacuate the bladder by means of this mass reflex, because normally in this person you can see they're having just with mild pain only, they're having lot of sweating, high blood pressure. So in these situations they can't undergo normal natural bowel movements, so for that we use this process, and many spinal segments are activated as a part of this reflex, hence it is called mass reflex. Means many spinal segments are involved in this process, so it's a mass reflex. So now we have completed that. Next we'll move on to this cerebellum and basal ganglia. So let us start now. The cerebellum is a coordination center. It start and stop signaling. So what it means cerebellum is mainly need for coordination. For example, now we'll say this finger to come and touch the screen correctly. So I can start at the same time, and I can also stop exactly here. So now my brain is in a correct coordination. But for the people who are having some cerebellum lesions or cerebellum problems, if I say them to start also, they'll like be somewhat unaware, and if we start also, they'll end somewhere like outside, they'll not end in the correct point where I said to stop. So they are not having perfect coordination in the case of cerebellum damage. So cerebellum mainly have 5 cells, 4 nuclei and 3 parts. So what is this? And also they have 3 cellular layers. So what is this 5, 4, 3? Let us see. So you can remember in backward order, 5, 4, 3. 5 cells, 4 nuclei. First we are seeing outside cell. In the cell next we are seeing nuclei. After that we are seeing the parts of cerebellum. Later we are seeing the different layers of the cerebellum. So first we will start with 5 cells. The main 5 cells are superficial in location. They are just superficial outside. So we have the 5 cells in different shapes. The first one stellate cell in the star shape, and it's mainly inhibitory. And next we have basket cell. It's like a basket shape. It is also inhibitory. And we have the granule cell. This is the only cell which is excitatory, which have many granules. And Purkinje cell is also inhibitory, and is the largest cell among all these cells of cerebellum, and we also have Golgi cells which are mainly inhibitory. So you can see like almost the cells of cerebellum are inhibitory except the granule cell. As it has granules, you can remember it will release the granules and excite. So like that you can remember the granule cell is the only excitatory cell, and the Purkinje cells is the largest cell among all this. Now let us see the 4 nuclei. Of course nuclei will be deep in location because cell is superficial. Inside the cell only will have nuclei, so nuclei will be of course deep in location, and we have 4 nuclei. The first one is, you can remember this like DEF-G or DEFG in order of alphabet. So D is for dentate nucleus. So this is the largest nucleus and the lateral most nucleus, and E for emboliform nucleus, and F for the vestigial nucleus, and G for globose nucleus. But you know actually the vestigial nucleus is the middlemost, the globose will be here, but to remember this in this order we have just put them like this. All nuclei are excitatory, with the very important point. So almost like the cells are almost inhibitory except the granule cell is excitatory, but you can see all the 4 nuclei are excitatory here, and the order is DEF-G. Dentate nucleus, the largest and lateral most. Emboliform, instead of vestigial actually globose will come. After globose vestigial will come, but to remember we have arranged. And next coming to 3 parts of cerebellum. Mainly we have spinocerebellum, vestibular cerebellum, neocerebellum. So what it is actually, for example, if we draw a cerebellum like this, right, this this is a vermis, these are the side lobes of cerebellum. This middle part, this is the spinocerebellum, and vestibular cerebellum will be here lower, vestibular cerebellum, and the newly formed cerebellum, neocerebellum. So these are the 3 parts of the cerebellum: spino, vestibular, neo. And next let us see the 3 cell layers. So if you see histologically, you will have the 3 cell layers. Mainly the first one is an external molecular layer, and it mainly have the stellate and basket cells. So as we discussed the stellate and basket cells, these both are together in the external molecular layer. And next we have the Purkinje cell layer. Purkinje cell layer have Purkinje cells and inner granular layer. As the name itself you can see granule cells, and one more also starts with G, that is the Golgi cells. So granule and Golgi cells are in the inner granular layer. Purkinje cell layer, Purkinje cells according to name. External molecular layer have stellate and basket cells. And remember one more thing, that inhibitory cells mainly use GABA while the excitatory cells use glutamate. So you can see here almost all cells are inhibitory, so they use GABA, but only the excitatory cell is a granule cell, so it will use a glutamate as a neurotransmitter. Next let us move on to the cerebellum. What is happening in cerebellum, let us see. So mainly cerebellum have 2 sensory sources which serve as an input for the cerebellum, and it also has an output. The only output of cerebellum is our Purkinje fibers, the Purkinje cell fibers. These are the output, and the input are 2 sensory sources for input. So you can see here the inferior olivary nucleus are the climbing fibers or olivocerebellar fibers. These are the input, and the spinal cord, from the spinal cord we have the mossy fibers or pallor fibers. This is also called as spinocerebellar tract, and the output is a start-stop signaling, which is done by our Purkinje cells. So you can see here inferior olivary nucleus. From the inferior olivary nucleus we are getting climbing fibers. This is also called as olivocerebellar because from the olivary nucleus it is coming to the cerebellum, and from the spinal cord you have mossy fibers or pallor fibers because this is called as spinocerebellar because from the spinal cord it is coming to the cerebellar tract, and the output is start or stop signaling. So now let us try to understand this. So first we'll start our starting point at the inferior olivary nucleus because it's an input. So first from the inferior olivary nucleus you will get a positive signal to the deep nuclei, and you will also get a positive signal to the Purkinje cell. Means inferior olivary nucleus is exciting both the deep nuclei and also exciting the Purkinje cells. So when the deep nuclei is excitatory, it will start the signaling process, and whenever the inferior nuclei activates the Purkinje cell, it will also of course start the excitatory process. But you know the Purkinje cell have an inhibitory effect on the deep nuclei. But from the Purkinje cell, now you have excited, right? Now the inferior olivary nucleus have activated the deep nuclei, and the inferior olivary nucleus also activated the Purkinje cell. Now the Purkinje cell is activated, and this Purkinje cell mainly have a negative effect. It has a negative inhibitory effect on this deep nuclei. So it will stop the excitatory action of this deep nuclei. But if this is stopped again, for example, now it has stopped, but again now we need to start the program. Now again we want to start some motor function. So again, how to start it? To start this, now of course we need to again block this Purkinje. So to block this Purkinje from the spinal cord, we are getting a spinocerebellar tract or mossy or parallel fibers, right? So they will activate the granule cell, and this granule cell in turn, it's a very huge one which activates all the three cells like stellate cell, basket cell, Golgi cell, right? Mainly the stellate cell and basket cell, which are activated by the mossy and parallel fibers coming from the spinal cord. They both and go and inhibit the Purkinje fiber. Now as the Purkinje fiber is inhibited, again the deep nuclei will become excitatory and start the program. So it will look somewhat confusing, but you will try to understand, it will be easy only. Till now you understood the story. The next story is, okay, now we have inhibited this Purkinje, now everything has started. And one more thing is, but if it has start, again we need to stop it. So how we will stop it? Here you have a granule cell, right? This granule cell have a capacity to activate even the Golgi, right? And this Golgi, which is activated by granule, this Golgi also have an inhibitory effect on this granule cell. So this Golgi will keep the granule cell in the check, because this is the main cell which is going to activate all the three cells. So now if this granule cell is again inhibited, means all this will get inhibited, then again Purkinje will get activated. So again this program will start. So this is very important. The deep nucleus are what? Nothing but these are the deep nucleus, right? Dentate, emboliform, fascicular, globose. So all this deep nuclei are under control of this inferior olivary nucleus and also spinal cord, because from here the signals will come and activate the stellate, basket, Golgi, granule, Purkinje, all this function like this. So this is a theory behind this. Now here I is inhibitory or negative and E is excitatory is positive, and is a feed forward inhibition and feedback inhibition. So you need to understand these two: feed forward inhibition, feedback inhibition. What are this? Let us understand. So you can see here the mossy fiber or parallel fiber. Now let us take the small part out of this and understand the feed forward and feedback mechanism. The mossy fiber or parallel fiber, we know they will activate the granule cell, right? The same process, they will activate the granule cell. This granule cell will in turn activate the stellate cell and basket cell, right? This stellate cell and basket cell, the final end result is that what? They inhibit the Purkinje cell, right? So you can see they are inhibiting the Purkinje cell. So this is nothing but feed forward inhibition, means from the mossy and parallel fibers, the signal is coming to the granule cell, right? And this granule cell is activating the stellate cell, means the signal is moving forward. It is going forward and inhibiting. So it is a feed forward inhibition. Whereas we also have a feedback inhibition. That is, you can see here the granule cell will also activate the Golgi, but the Golgi is coming back and inhibiting the granule. You can see Golgi is coming back and inhibiting granule. So this is a feedback inhibition. So very important process, feedback inhibition and feed forward inhibition, to understand in this topic of cerebellum. As I said, cerebellum have three parts, right? Now let us see that functions of these three parts also. First one we'll see the spinocerebellum, which is the middle portion of cerebellum, right? So it is mainly useful for the coordination of motor movements, of course. And the nuclei here are mainly associated with this spinocerebellum, like in the middle, right? As I said, the fascicle is in the middle. Next, of course, globose will come, emboliform. So just in order, fascicle, globose, emboliform, except the dentate nucleus, because dentate nucleus is like somewhat at the edges. It's not in the middle. So dentate nucleus is not involved in the spinocerebellum. Next, coming to the vestibular cerebellum. This part is mainly useful for balance and equilibrium. So remember, spinocerebellum is for coordination of motor movements. You can remember like spinal cord is there, right? So of course if spinal cord is there, it will coordinate the motor like that, you can remember. Vestibular cerebellum. So why it got this name is because it's associated with the vestibule. You know what is a vestibule? It's present in our inner ear, right? So with that also it has some. So you know, vestibule for balance and equilibrium of ear, right? The same for cerebellum also. And also regulating the vestibulo-ocular reflex. It's also related to this vestibulo-ocular reflex. And it's a mainly component of flocculonodular lobe. So flocculonodular lobe is associated here, because as I shown in the diagram, like here, this lobe one is actually flocculonodular lobe where the vestibular cerebellum is present, right? So it's associated with flocculonodular lobe, and the nuclei here are not found in the cerebellum. Yes, of course there is no nuclei there, and vestibular nucleus is present with, of course there is a vestibular apparatus. Only vestibular apparatus is associated with the vestibular cerebellum. With spinocerebellum we have all the middle nucleus like fascicle, globose, emboliform, no dentate because it's at the edges. So at the at the neo cerebellum you can expect the dentate, because dentate is at the edges. So if you have anatomy, if you know the anatomy of cerebellum, you can understand this everything easily. So neo cerebellum is a planning a motor movement. So for the planning, it's new. You can see new one. You are planning for new things. So like that you can remember planning a motor movement. So vestibular word will come balance and equilibrium. Spinal word will come coordination of motor movements. New plannings for the motor movement. So nuclei is the dentate. Dentate is actually the largest one and the most lateral one, of course. Now let us see the cerebellar lesion. So if there are some cerebellar problems, lesions in them, what happens? So of course the main thing is start-stop signaling will be sure affected. So main findings are coordination on walking. So walking coordination, that's a person can't walk straight forward, so that is called ataxia, also called drunken gait, like a person who is drunken, like that he may walk. And the past pointing, so beyond the stop point. So if we say to stop here, but no, he'll go beyond and stop somewhere, that is a past pointing. And rebound phenomena, like now I'm saying like this, but they can't do. If they do like this, they're stuck here, or if they do like this, they're stuck here. They can't do like this, that is a rebound phenomena. And nystagmus, that is continuous eye blink movement. So we will blink at some time, we can stop, but if they start blinking like movement on opposite sides, so for example this is eye, first we'll see this side, next we'll see this side, but that person will continually move his eyes that side and this side, that is called nystagmus. And pendular knee jerk, so first in a normal person, if you do knee jerk, our muzzle will undergo contraction and again it will stop, but here the person, if you do knee jerk, it will move like this only, like pendulum, like this it will move. And next we have this diadochokinesia. It's an alternative supination pronation, not possible. So actually what supination pronation alternate, this is supination, right, this is pronation. So it's like in a music, if you do like this, right, in music class, like this, supination pronation. So that person can't do like this. Sometimes he will do like sometimes he will do like this, only one time we may do supination, more pronation, more supination. So like that it will be alternate, it's mismatched in case of the cerebral dysfunction process. And intention tremors not during rest. So intention tremors means in a rest this person will be normal, but if you suddenly say him to bring some item to, then he start like this movements, and he will bring that item. For example, if a cerebellar patient, now I say to catch him this pen, he will go like this, like this. So that is a tremors. So tremors are seen in the cerebellar lesion patient. And next let us see the basal ganglia. So basal ganglia, in basal ganglia also there are tremors, but inhibitory at rest. So actually in basal ganglia, what is the problem is, even in the rest the patient will have tremors like this, but in cerebellar findings, whenever you say any work, then only they will have tremors. So it is an intention tremor in the case of cerebellum, but in the basal ganglia, at the rest only they will have the tremors. So findings are here: suppression of voluntary and involuntary movements. So both voluntary and involuntary are suppressed, because you can understand at the rest only the person is not able to move. And the nuclei here is mainly caudate nuclei, which is an input nuclei, and the GABA is a neurotransmitter there, and the planning of motor movements, and the putamen. So these are the main functions of the basal ganglia. Putamen input nuclei is here, also they have the GABA as a neurotransmitter. So actually striatum is a pathway, the both caudate nucleus and putamen. So if the caudate and putamen together, it called a striatum. And globus pallidus is an output nuclei, here also GABA, so everywhere GABA is there here, and it is divided into interna and externa, that is globus pallidus interna, GPI, globus pallidus externa, and lenticular nuclei together means putamen with the globus pallidus. Putamen with the globus pallidus is called lenticular nuclei. Caudate nucleus with the putamen is called striatum. Next let us see substantia nigra. Substantia nigra is dopamine, and subthalamic nuclei is only excitatory, so it has glutamate as a neurotransmitter. Substantia nigra neurotransmitter dopamine. So let us see the function of basal ganglia. Basal ganglia have direct pathway or indirect pathway. So direct pathway is facilitation of movements. The direct pathway is GPI inhibited, means globus pallidus is inhibited. So if the globus pallidus is inhibited, there will be facilitation of movement. Whereas in an indirect pathway, there is inhibition of movements. The movements are inhibited. So you can say here the striatum, motor cortex. Striatum is activated, caudate and putamen are activated, right? Means GABA is released. So it's inhibitory to the globus pallidus. So not like this. We'll start the fresh one, we'll understand. So first ventral anterior nucleus in the thalamus is excitatory to the motor cortex, right? So this motor cortex will in turn excite the striatum, and this striatum will have an inhibitory effect on the globus pallidus interna at rest. So as this globus pallidus interna is inhibited, this in turn will inhibit the thalamus. So at the beginning, thalamus is starting all this process, but because of release of GABA from the striatum, this globus pallidus is inhibited. As the globus pallidus is inhibited, it will also inhibit the thalamus. So all this process is stopped. Means the person now is having the facilitation of movement. This is a direct pathway. So direct pathway is nothing but direct pathways. GPI is inhibited. Globus pallidus interna is inhibited. If the globus pallidus interna is inhibited, means even this whole pathway will be inhibited. So if whole pathway is inhibited, means what? There is facilitation of movements. Means movements are going on. Now let us see the indirect pathway. So indirect pathway we have GPIs need to be activated. So here GPI need to be activated. Means there is inhibition of thalamus. So let us see here. So first thalamus is there, ventral anterior nucleus. It activates the motor cortex. The same process. The striatum will be releasing GABA, so it will inhibit the globus pallidus externa, and this globus pallidus externa will inhibit the subthalamic nucleus, and this subthalamic nucleus is actually a positive, means it's stimulating the globus pallidus interna. So see, subthalamic nucleus is actually activating the globus pallidus interna. So now if we block the subthalamic nucleus by globus pallidus externa, then this globus pallidus interna will be inhibited, and of course the thalamus also will be inhibited. So our final goal is to inhibit the thalamus, but in the direct pathway we directly inhibited without any of this subthalamic nucleus and without this globus pallidus externa. If you remember the direct pathway, directly by the striatum we have inhibited the globus pallidus interna, but now into the indirect pathway we have two indirect substances, that is globus pallidus externa and subthalamic nucleus. Subthalamic nucleus is usually excitatory to the globus pallidus interna. So if we inhibit this subthalamic nucleus, of course the globus pallidus interna will be inhibited and the thalamus also will be inhibited. So all this process is inhibited. So the final one is role of dopamine needed for overall facilitation of movements, mainly by direct pathway or either by indirect pathway. So actually dopamine is the main neurotransmitter required for both either direct pathway or indirect pathway. So let us see what is that. So mainly we have substance here dopamine. So dopamine via D1 receptors, it will activate the direct pathway, so it will lead to facilitation of movements. And by D2 receptor, it will inhibit the indirect pathway. So if you inhibit the indirect pathway, it will lead to facilitation. Very important point. In direct pathway, you need to activate the direct pathway, then it will lead to facilitation. But here you need to inhibit the indirect pathway. Why we are saying we need to inhibit the indirect pathway? Because here if we inhibit the subthalamic nucleus, then the globus pallidus interna only will be inhibited, then only thalamus is inhibited, then only there will be facilitation of movement. So finally we will see if there are basal ganglia lesions, what happens. Of course before only we are seeing that basal ganglia normal function is suppression of voluntary and involuntary. So now here suppressing, basal ganglia is suppressing them. So now if problem in basal ganglia means there will be involuntary movements, of course. So now involuntary movements will be there in the person, like voluntary are in our control, involuntary means without our control. So without our control there will be some movements in this, and the person will also have chorea, that is caudate nucleus lesion. Chorea means the person will move like snake like movements like that, and caudate nucleus lesion because of caudate nucleus, C for C. And ethitosis is globus pallidus lesion, and hemibalisms means subthalamic lesion. And subthalamic lesion means here you can understand subthalamus is inhibited. And dopamine deficiency means Parkinson's disease. If no dopamine, it will lead to Parkinson's disease. And bradykinesia, paucity of movements. Resting tremor, pill rolling tremor means even in rest the person is now having tremors because involuntary movements are there in them, right? Basal ganglia is, basal ganglia controls the involuntary movements, right? Now as the basal ganglia suppress the involuntary movements. Now there is a problem in the basal ganglia itself, so no one to suppress the involuntary movements. So person will have pill rolling tremors even in the rest. So the major difference between basal ganglia lesion and cerebral lesion is, in the cerebral lesion only intended tremors, means whenever you say the person to work, then only you will have tremors. But here in the basal ganglia, even at the rest the person will have tremors. So neocerebellum or cerebrocerebellum is useful for planning. Yeah, this one we already discussed. So by this we completed a complete revision series of motor physiology.